All right, everyone. Hello. Thank you for joining. Before we get started, I'd like to just welcome you to this healthy lifestyle talk for how to prevent colorectal cancer. This healthy lifestyle talk will be presented by Dr. Robbin Cromer-Tyler. A little bit about Dr. Robbin Cromer-Tyler. She's a graduate of the University of Nevada School of Medicine in Reno. Dr. Cromer-Tyler completed her 5-year residency in general surgery at the University of Tennessee in 1992. She is board certified and has been recertified twice, last being in 2015. After practicing in the rural community of Lower Alabama, she moved back to Bishop in 2007. Dr. Cromer-Tyler moved back to the Eastern Sierra to be closer to her family in Reno. She continues to expand her knowledge and skill, particularly in gallbladder and hernia surgeries that can be done robotically. She enjoys skiing and some hiking. Her husband, Jim, is known for his filming of the Bishop Bronco football team and working with Laughing Parrot. Her education is as follows: medical school in the University of Nevada School of Medicine, residency at the University of Tennessee, the board certification of the American Board of Surgery. Her special interests are in robotic surgery. And for anyone who did not know, she is a former chief of staff here at Northern Inyo Healthcare District, serving 15 years nearly in our district. Without further ado, I will hand it over to Dr. Cromer-Tyler to get started with the healthy lifestyle talk.
Good evening. I'm going to talk a bit about just the basics about colon cancer. Unfortunately, the greatest risk factor for having colon cancer is the fact that we're born. It occurs in people of varying diets, everything from vegans to omnivores, although the rates, depending on what type of diet you choose to eat, are different, with the more plant-based diets having a lower rate, but it's not zero. So part of the reason I do this, aside from the fact that I was trained to do it, is my own brother wouldn't have his baseline colon screening done. So at 57, after years of me nagging him, he wouldn't have it done. And lo and behold, he had colon cancer. But the cancer was confined to the surface of a polyp. And by having that polyp removed, he was completely treated. There was no chemotherapy, there was no surgery. All he needed to do was increase monitoring. And what that implies, because he's a first-degree relative of mine, is that I need to be screened more frequently. So next week, I'll be having my 3rd colonoscopy here in Bishop. I've had them all done here. And I'm encouraging people to do a form of screening that is appropriate for them. So let's talk a little bit about the basics of colon cancer. I can get this computer to work here. All right. So colon cancer is the 2nd most common cause of cancer deaths in the United States. It affects both men and women. As you can see by the relative numbers up there, it's a pretty equal distribution. But those that are described there are people who have no family history. So this is their lifetime risk. So about 1 in 23 men will get colon cancer, and 1 in 25 women will get colon cancer. The things that we look for are changes in the bowel function, feeling like you have to have a bowel movement without feeling relief of symptoms. So you just can't get emptied out. Blood in the stool of any kind. If you can see it when you wipe, you can see it in the bowl, it should be investigated. New onset of anemia, particularly iron deficiency anemia, is associated with blood loss through the GI tract. And so that's the reason why when people develop anemia, or they have a stable anemia that worsens, we go ahead and recheck their colon. Cramping and abdominal pain. This is really more related to areas where the tumor has grown large enough to start constricting the inside of the colon, or what we call the lumen. Weakness and fatigue for many people are the first signs, because they're anemic and they've had chronic blood loss, and it may have been going on for so long that you can't see it. So that was the reason, that was the beginning of the stool tests to look for colon cancer. Unintended weight loss, any significant weight loss in a short period of time, 3 months, 6 months, a year, is significant, and we look into it. Constipation, again, because of the narrowing of the lumen of the bowel, and then diarrhea. Sometimes when there's a constricting lesion or something that has constricted the lumen of the bowel, things build up behind it. And so it relieves. At first, there's a hard form stool, and then it's loose. Alternating diarrhea and constipation is a really common thing for adults in America. So it doesn't always signify cancer. Fortunately, it is probably the last thing that is causing, the last symptom that we look for causing cancer. But if it's never been investigated, it should. The problem with waiting for symptoms is that by the time you develop symptoms for colon cancer, you are already pretty far along in the curve. And this shows why. These are an attempt to look at different types of situations with colon cancer. So stage 0, which is up at the top, is the kind that my brother had, where there's a polyp, and just on its surface, there was a colon cancer. The second one shows penetration into the polyp stalk. That shows us that it could potentially have spread. Stage 2, it starts to go through the colon wall. And stage 3, it's involving lymph nodes. Stage 4, it is spread to other parts of the body. The point about the surface of the inside of the colon is the colon cancer starts on the surface, and then its stage is by how much depth it penetrates through the wall. Once it gets below a certain level, there are blood vessels and lymphatics, just like you have in all your other tissues of the body. That's how it spreads. It can spread directly all the way through the wall into surrounding structures, or once it's picked up either by the blood system or the lymphatic system, it can spread first usually to the other lymph nodes, and secondly to the liver, lungs, and other parts of the body. Who should be screened? Now, this has changed in the last few years, and finally insurers are catching up with the new screening recommendations. Currently, it should begin at age 45. The most important thing, other than getting a baseline screening, is that screening is a repetitive process. So just having once isn't enough. If you want to have a colonoscopy to be your method of screening, the baseline is once every 10 years, and then any findings would adjust that history. The other methods, such as stool tests, the new DNA studies of the stool, they're all repeated, but at a much higher rate of frequency, 1, 2, or 3 years. The people who have had any symptoms, of course, the people who've had who've had symptoms, of course, should be screened. And they should, the kind of symptoms they're having would determine which method of screening we would recommend. If you have a family history, the baseline should be at age 45 or 10 years before the first person or the youngest person in your family who had the cancer, then at least once every 5 years. If you have a personal history of an inflammatory bowel disease or have had polyps in the past, then you need more frequent studying. Let's see, history. There are polyposes. In this valley, actually, we have non-polypose colon cancer. It's called Lynch syndrome. And there are 2 genetic strains that run through certain families in the valley. Those families have a high penetration of colon cancer. So that means that a high number of their family members are going to get colon cancer. And so the sooner we start screening, the sooner we can find it or find that it's developing, and intervene to prevent progression to stage 3 and 4 disease. A personal history of adenomas, which is a type of polyp. There are many subtypes of adenomas. There are really expansive algorithms. The ones that I like to use are the National Cancer Consortium Network.org. They make recommendations based upon your family history, the types of polyps, their size, their location, their number as to how frequently you need to be screened. I use that for, most of the time and refer to it frequently because it's updated about every 1 to 2 years. How to be screened and where? It varies with your personal history in the family. If you have no family history, no personal history of polyps, no symptoms, then you should start at age 45. You can do colonoscopy, which is once every 10 years if it's normal. Cologuard, which is a DNA test of the stool, which is done every 3 years. And the IFIT test, which should be done yearly. If any of those tests are positive, the next step is an endoscopic evaluation of the colon, whether that's a flexible sigmoidoscopy, which is frequently paired with an IFIT, or a full colonoscopy. Again, if you have any symptoms or you have any personal history of these things, it's important to follow up. What causes colon cancer? Colon cancer, to date, that what we know is there is a localized genetic mutation on the cells on the surface of the colon, right where the colon, where the cancer arises. Why it happens at that one site, we cannot say at this point. There are multiple cellular DNA changes that go on that send different signals to the cells there that cause this mutation to occur. At this time, there isn't anything that we have developed or discovered that can stop this from happening. There are things, of course, that we know will reduce your risk, such as having a healthy diet, lots of fruit and vegetables, exercise, maintaining your body weight, controlling diabetes, as well as there is some data that has suggested off and on over the last 10 years that possibly some form of anti-inflammatory could affect this. And recent data that I read basically suggests that an aspirin a day, low dose, may prevent colon cancer. But it'd probably be another 10 to 15 years before we have enough data to say that that is really true. Again, we do not know why this starts, and we know that it occurs in people of all diets. What can you do to prevent it? Keep your weight in a normal range. Don't smoke. No heavy drinking. Be active. Eat fewer processed foods and red meat. Processed meats, particularly like kielbasa, salami, those kinds of meats have a high, people whose diets are heavy in those tend to have higher rates of colon cancer. Treatment, the treatment for colon cancer, the very first step is removal of the tumor. And at the time that we remove the tumor, we do our best to encompass as much of the involved tissues as possible. That means taking the lymph nodes in the area that drains this tumor. Unfortunately, you can't tell visually or by your hand necessarily that they're involved unless they're pretty far advanced. And in that situation, as in any time you have a biopsy, we need to wait for the pathology before we know what the stage is. I frequently get questions when I make a diagnosis based on a polyp. What stage is it? Well, there's a lot of workup that needs to be done. there needs to be blood tests to look at the liver, a CT scan of the chest and abdomen, and some other additional tests to look for tumor markers. Tumor markers are not 100%. They are something that we check in each person before we would remove a tumor. And then if it goes down afterwards, after it's removed, that tells us, okay, this may be a marker that we can follow to try to find a recurrence early. There are schemes and algorithms already developed for how frequently we see these patients and how frequently we repeat their endoscopy to look for recurrence of disease, how frequently they get a CT scan again. So this is just a demonstration on how most of the treatment regimens go. Stage 0-1 is where we want to find you, just like my brother. We want to find the disease early and eradicate it. This is one of the few preventatives where we actually intervene and are showing a decreased incidence in the disease in the people that get studied. Unfortunately, there's still 30 to 35% of people that do no form of monitoring. The most important thing I can say is please get screened, especially if you have any of the risk factors. Most colon cancer is not genetic. Only about 20% of colon cancer, just as with breast cancer, is genetic. So we're all at risk. We all need to pay attention to. Are there any questions I can answer?
Yeah, you have one from the chat, actually. It's of these two options, colonoscopy versus stool DNA. Yeah, stool DNA versus iFit. Is there an option that's superior to the others for colon cancer screening?
Each has different sensitivities. The most important and the most repetitive thing that the American Cancer Society say, whatever method you're going to do, keep doing it. There is no test that's 100%, including endoscopy or colonoscopy. The sensitivity and specificity is highest with colonoscopy, meaning you're more likely to see something and you're more likely to find something that's related to colon cancer. The next most sensitive, we believe, is the DNA study. The DNA probes were developed in Northern Europe against obviously a predominantly white population to test for cells that are sloughed in the stool. Your colon lining sloughs just like your skin does every day. So it's a funny experience. You get this box. It has a little platform that you put on your toilet. You poop in a big jar. You send that whole specimen and a little swab of it back to the company, and they process it. They separate the stool from the cells. That is about an 85% sensitivity for what's called advanced lesions. It is not diagnostic of colon cancer. It will find somebody who is possibly got colon cancer or somebody who has a polyp that is sloughing cells that is leading to colon cancer. So that's the difference between those two. iFit is a very inexpensive test. It can be done, you can do it at home and send it to a lab and have it tested. All it looks for is evidence of blood in the stool. If it's positive, then again, a second method of evaluation of the colon is indicated. There are some X-ray techniques in the last decade. The capsular endoscopy has become popular. It really hasn't taken off in colon cancer screening, but is used frequently for things where the areas that we can't get to with the scopes between the third portion of what's called the duodenum or small bowel, that all those feet of small bowel down to the where it joins the colon can be seen on the camera. So it looks for bleeding lesions, other kinds of abnormalities. CT Coliography is a technique where they use water as a contrast material. The problem with that is that there aren't that many radiologists who are trained to read those studies. And it's it's like having a barium enema. So there is still those discomfort issues. Colonoscopy in our hands here is done under sedation. It's either moderate conscious sedation, where the surgeon directs a regular RN to administer medications. We have different protocols on how to do it safely. It's done in the operating room. You're fully monitored. Everything we need is there to manage any problems. For those people who have cardiac risk factors, respiratory risk factors, severe anxiety about the procedure, we can ask an anesthetist of some form, whether that's an MD or a CRNA, to administer a different set of drugs, which have a deeper level of sedation, more rapid onset, and wear off more quickly. The problem is that insurers don't want to always pay for that. It is covered by Medicare, and believe it or not, it's actually covered by Medi-Cal most of the time. But the private insurers don't want to pay for that because we have such a long track record of doing it with moderate conscious sedation. All of mine have been done with moderate conscious sedation, and I remember absolutely nothing. So a lot of it has to do with how anxious you are about the procedure. If you're really anxious, it's much harder to get you to a relaxed state to do the procedure. There are a few people who can tolerate a colonoscopy without sedation. I personally, in my hands, I've never been really successful with that, so I don't do it. Dr. Robinson, who also does colonoscopies, has been successful with it, but she's highly selective on who she'll do. And the fallback is always, if we're not being successful, we would sedate you. iFit is a yearly test. It's reliable for finding blood. But then again, the thing to remember is that if it's positive, it needs to be followed up with some sort of endoscopic evaluation of the colon. Anything else?
We have another one in the chat, but if one of you want to ask first, I'll leave it to you.
Good.
The other one in the chat was asking if, sorry, it's kind of they said if I'm more concerned about, my folks getting tested or getting screened, or maybe like I have an older sibling and they are kind of refusing, but I see kind of the value of them getting this test done. Is there something that they could say to them to maybe convince them to go? I mean, other than having them come into talks like this, anything you could tell someone who's maybe on the fence or just won't go?
I think that is the biggest hurdle that we have in terms of really treating colon cancer and finding colon cancer, is people have very strong opinions about it. Everybody's got somebody in their life who said it was the worst experience of my life. And I can tell you that not always, but sometimes I have had that person there and they slept through the whole thing and were totally comfortable, but yet it was the worst thing in their life. A lot of people don't want to go through the prep. It's unpleasant, but it's necessary. If your colon is not cleaned out, I can't see the wall. That increases the risk of a complication, meaning putting a hole in your bowel where I would have to do surgery to fix, or missing a polyp. Polyps aren't always easy to see because there are those folds inside the colon. And so it can be around the lip of that. We do our best to see as much as we can, but depending on the study you read, anywhere from 6 to 30% of polyps are missed on a good, well-prepped colon done by an experienced colonoscopist. I think that there is apprehension about getting a diagnosis. There are people who have issues about dealing with that part of the body. And there's people who have issues, oh, I don't want to go through the prep. I don't want to do this. There are ways that we can help you. There are ways we can do with anxiety, but unfortunately, I haven't discovered the magic phrases to get people to do this. So as I said, with my own brother, I nagged him until he did it. So.
There you go.
Are you suggesting that there should be 3 screenings? Are you suggesting that we should do 3 screenings? The reason why I'm asking that is the one that we did at home with the bowels, with the sending the information, the feces into the clinic, wherever, and coming back. My husband proved his came back positive, mine came back negative, but that was only one test that we took.
Right. In today's world, one positive test is an indication to do a colonoscopy.
Yeah, well, he had his colonoscopy. And of course, that came, praise the Lord, that was fine. But
Right. So when I say repetitive, as I said, a baseline colonoscopy would be repeated every 10 years. The DNA tests of the stool are repeated every 3 years. Okay. The IFIT should be done every year. So it depends on which regimen you and your provider decide to use. The fallback is that if any tests like that are positive or you have symptoms, a colonoscopy is indicated. Some people need to have the additional, if they're having symptoms, want the additional testing done prior to considering a colonoscopy for the same reasons that I've mentioned. Right now, we're working on a project with the CMO to build a more broad colon cancer screening program, utilizing more at-home testing that does not involve Cologuard. Unfortunately, because it's new, like many new procedures, Cologuard isn't covered by all insurers. So there's the trouble of coverage. These tests, the Cologuard is somewhere between $500 and $700 to have done. The paper tests like the IFIT are less than $50. The colonoscopy, of course, is the most expensive because it involves providers who have skills. What else?
I think that's all we have in the chat. Yeah.
Okay, I think that you're going to show people some of the stuff, other things that we do in our OR.
Oh, yeah. Yeah. If there's no other questions, I think we'll move on to that. All right, give us just a second. We'll set up a short video featuring our OR and surgery floors.
Tammy, I am the perioperative manager here at Northern Inyo Hospital in Bishop. So our unit runs the surgeries, which includes the 3 ORs. And then we also have sterile processing in there, which supplies all the instruments for surgeries, as well as all the clinics. And then across the hall, we have the rest of the perioperative unit, which includes PACU, pre-op, infusion. And we also do wound care here, which is down in DI. So in the pre-op area, we get patients ready for surgery. And then in the PACU, which is the post-recovery area, so after your surgery, you recover in there with the same nurses, which is nice, so you'll be comfortable with them. And then we also do infusions in there, so all kinds of infusions, so we help the community a lot in that way. Our OR staff is really diligent to the point where they are all watching each other. And if the sheet that's covering the patient, let's say we have drapes that cover the patients, if the little tip of that touches something that's not sterile, somebody sees it and they do everything over again because it's so important for infection control.
Northern Inyo Hospital has 3 OR rooms. This is one of them. They're all set up pretty much the same way. This room is used for multiple different types of surgeries that we do here.
This is the anesthesiologist command center, basically. Monitor vital signs, give gases. This is the Pyxis for medications and holds all their supplies. This is kind of the bread and butter for an anesthesiologist.
The room 2 houses our Da Vinci robot. And then we have the standard equipment in all the rooms. The cautery, the Neptune. This is our Olympus tower, which we use for our scopes, laparoscopic surgeries, cabinet of our supplies, and then we have the anesthesia machine and our Omnicell for our medications. So we have our sterile processing. This portion would be, we call it the dirty part, but that's where everything gets like their first cleaning. And then this is the washer. So equipment, once it's hand cleaned, it goes in this machine, and then it'll actually come out the other side to where it gets sterilized.
So you go to your surgeon, you find out you have to have surgery. You don't want to have surgery. There's a physician that talks to you separate from your surgical physician, which is nice, and they can give you information to maybe calm you if you're still worried. One of our peri-op nurses calls 2 days prior to your surgery, and you can voice any of your concerns to them. I think it's information. Most people are missing the information part, so they can ask any question that they might have, and the nurse will either have the information for them or will be able to provide information after they get it, and they will call that patient back. And that usually solves most of the problems of the fear. And then, of course, they get here, and all of our nurses are so great at calming patients down.
So this is the PACU. This is where we bring our patients to recover from surgery. We bring them here, and then we keep them anywhere from an hour to 2 hours until they're ready to go home. For some surgeries, we bring them up to the med-surg floor, and they get watched for a couple days. So we monitor, we got the monitor, we got all the supplies here. We've got the emergency supplies, and we've got the stethoscope and the suction supplies. So everything we need for recovery is here, easily accessible. The patient needs it, and we bring the patient's family here so they can hang out with them, and yeah.
Yeah, this is our rescue equipment here in the peri-op area, so that's our malignant hypothermia cart, which is a super rare thing that happens after a procedure, but we have it right here in case that starts to happen. We monitor the patients for that always. And then this is our crash cart. So if something started to happen to the patient, we have this right next to the bays where they're recovering. The patient comes for screening for something, like in DI perhaps, and then they see their physician again who's gone over that. And then maybe they need a procedure to check whatever might have been found in a screening, and then maybe they need surgery, or maybe you've hurt yourself climbing or skiing, and then you might come see our ortho guys and have a surgery there, and then after that you go to recovery. We come see you come from home, we do pre-op, and then you come to our PACU, and then if something else happens where maybe you need an antibiotic or chemotherapy, we would then be the same staff doing the infusions for the community as well, and wound care and along the same lines. Get bit by a dog, you fall and hurt yourself, you have a wound that's chronic and you've been going out of town for a long time, we have the service here and you can actually be here and recover at home. With all of our services, we offer so much. I think our hospital, what makes it so special is we all live here, so we are part of the community. Like I grew up in Mammoth, and then I went to school and was a nurse, and I worked in a bigger hospital, and I finally got to come home, and I work here now, and I get to work with all these fantastic people. Another really cool thing is all of us, like I like everybody I work with. It's very uncommon at other hospitals, I have to say. And our mission statement is one team, one goal, your health. So we're part of the community, we're here to help you, and you get to go home after you see us. Thanks for watching this healthy lifestyle talk, and thanks for letting me and my fellow staff show you a little bit about what we do here at Northern Inyo Hospital in Bishop.
All right, I think that is all we have for everyone. Thanks for coming to this healthy lifestyle talk. If you have any questions or want to watch anything you saw here today, you can see that on the Northern Inyo Healthcare YouTube page, as well as the Facebook page. So make sure you follow us there if you want to check back and see any of this again.